Good evening, everyone. I'm Dr. Sakshi Rajaria. I'm assistant professor in Department of Pediatrics, KEM Hospital, Mumbai. I welcome you all as part of the Gaucher Disease Awareness Month. We are here in today for an academic feast on the prevention of Gaucher disease and other lysosomal storage disorders. This has been made possible because of the efforts of the Lysosomal Storage Disease Support Society, International Gaucher Alliance, and Sanofi. I would now like to begin this session by inviting Dr. Mamta Muranjan ma'am, professor and in charge genetic clinic, KEM Hospital, Mumbai, consultant in clinical genetics, PD Hinduja Hospital and SRCC Children's Hospital, Mumbai. She will be now presenting an overview of Gaucher disease and other lysosomal storage disorders. Over to you, ma'am.
Thank you, Sakshi, for the kind introduction. And I thank, at the outset, I would like to thank Suyog and others from the International Gaucher Alliance and Sanofi for allowing us to be part of the commemoration of Gaucher disease. That's October, which is commemorated as the Gaucher Disease Awareness Month. So I have been asked to speak on lysosomal storage disorders and Gaucher disease, and I'm going to talk a bit about how these conditions would be relevant in obstetric practice. So just give me a moment to share my screen. Yeah, is my screen visible?
No, not yet.
Not yet. Okay, what about now?
Yes, ma'am.
Thank you. So the basic question here to understand lysosomal storage disorders is the function of this tiny little subcellular organelle, which is the lysosome. This is a membrane bound structure that is present in almost every cell in the human body. And this lysosome performs a very critical function in the overall cellular homeostasis. This little membrane bound lysosome contains several hydrolytic enzymes, and these enzymes are involved in the metabolic pathway for degradation of complex molecules. And several variety of substrates are degraded within the lysosome, and these include complex glycoproteins like glycolipids, sphingolipids, several gangliosides, and cholesterol. And all these lipids and cholesterol gangliosides are components of cells like the neurons and as well as several types of cells in the body. So since these lysosomes and the substrates are ubiquitously expressed in multiple organs, in a lysosomal storage disorders, several organs will be affected. So this is a multi-system disorder, which means that there would be signs and symptoms in several related to dysfunction of several organs. So the metabolic disorders which result from a dysfunction of lysosomes, particularly deficiency of these hydrolytic enzymes, a deficiency of transport proteins, membrane proteins, all result in lysosomal storage disorders. And the problem here, the basic pathology, is excessive accumulation of undegraded complex lipids within the several cellular structures in the body. So there are about 70 different lysosomal storage disorders described today. And the most common out of these 70, 40 disorders are related to deficiency of a single or multiple lysosomal enzymes. So what these lysosomal enzymes do, they essentially remove sugars and other groups like N-acetyl-nuramine and N-acetyl galactose, N-acetyl glucose from the complex glycolipid or sphingolipid molecule. So as shown here, an enzyme would, so for example, an enzyme acting at this step would remove galactose from the molecule. In a second step, another enzyme would remove N-acetyl-nuraminic acid, and so on till you're finally left with the backbone, which is the ceramide. So it is easy to understand that if any one of these enzymes is deficient, there will be accumulation of a partially degraded substrate of that specific enzyme. Now, lysosomal storage disorders are classified depending on the nature of the substrate that is accumulating. So there are several examples, like if mucopolysaccharides or glycosaminoglycans accumulate, the disorder would be mucopolysaccharidosis. If sphingolipids accumulate, these group of disorders will be sphingolipidosis. So now, individually, lysosomal storage disorders are rare. So about 1 in 50,000 to 1 in 57,000 to 1 in about 42 lakh babies would be affected by a lysosomal storage disorder. So this incidence varies according to each disease. So some, like Gaucher disease and Fabry disease, are very common in India as well as in other parts of the world. So about 1 in 60,000 live-born babies will be affected by Gaucher disease, whereas some type of neuronal ceroid lipofuscinosis are extremely rare, and they would be a handful of people affected by some of these neuronal ceroid lipofuscinosis. Now, even though these disorders are individually rare, collectively, about 1 in 2,000 to 1 in 5,000 babies born would suffer from a lysosomal storage disorders. And in India, the common disorders are Gaucher disease, Fabry disease, and mucopolysaccharidosis. Now, there is some ethnic predilection. So, amongst the Ashkenazi Jews, Gaucher disease is very, very common with a very high carrier frequency of about 1 in 80. In India, we do not as yet see any specific predilection in any particular part of the country, in any community, any caste, or any specific geographical region. Now, all these disorders are inherited disorders. Most of them are autosomal recessive, which means that the mother and the father of an affected patient are carriers. And exceptions to this are X-linked disorders like Hunter syndrome or MPS 2 and Fabry disease. These two disorders are X-linked recessive, which means that only males are affected. The mothers are carriers. So a carrier mother transmits the disease to her son, and her daughters, 1 in 2 daughters, or 50% of the daughters would be carriers, 50% or 1 in 2 of her sons would be affected. Now, I already mentioned that lysosomes and the substrates are expressed in multiple organs in the body. So the way to suspect lysosomal storage disorders is by detecting clustering of symptoms and multiple organ involvement, and clues that should result in suspicion of a lysosomal storage disorder include coarse facial features, umbilical inguinal hernias. So an infant or a child less than 2 years of age having an inguinal hernia, having an umbilical hernia is rather unusual, especially a hernia requiring surgical correction. So that should serve as a red flag. Similarly, short stature, multiple skeletal deformities in the form of joint stiffness, enlargement of the liver, enlargement of the spleen, progressive muscle weakness, or a child with a neurodegenerative disease, presence of neurological symptoms such as various types of seizures, involuntary extrapyramidal movements, ataxias, and ophthalmologic abnormality should lead to suspicion of a lysosomal storage disorder. Now, having suspected a lysosomal storage disorders, the diagnostic tools, there can be three options. One, you would like to detect a specific substrate, and previously, before molecular investigations and availability of enzyme activity were available widely, the way these disorders were diagnosed was by doing a bone marrow and detecting presence of storage cells. So for example, here you see a typical cell, a macrophage, which is enlarged eccentric nucleus, and this very typical crumpled silk or wrinkled tissue paper appearance. This is a Gaucher cell, and presence of Gaucher cell in the bone marrow would be considered diagnostic of Gaucher disease. And on the other hand, here you see a cell with a bubbly appearance or a foamy appearance of the cytoplasm. This is a foam cell typically seen in Niemann-Pick disease. So prior to the era of enzyme testing enzyme activity and molecular, this histopathology was the basis for diagnosis. However, now the gold standard of diagnosis is by estimating the enzyme activity in either the peripheral white blood cells, skin fibroblasts, or even a sample obtained by a dried blood spot sample obtained by a heel prick. And finally, in today's practice, confirmation of the diagnosis by molecular testing of the specific gene will be mandatory. Now, coming to Gaucher disease, as I mentioned, it is the most common amongst the lysosomal storage disorders. And this Gaucher disease results from disease-causing mutations in the GBA1 gene. So this mutations in this GBA1 gene result in deficiency of the lysosomal enzyme glucose cerebrosidase, because of which glucose cerebroside substrates starts accumulating within the lysosomes, and progressive accumulation of this substrate leads to enlargement of the lysosomes, enlargement of the cell, and here you can see formation of Gaucher cells, which is nothing but an activated macrophage. So these cells are typically seen, these cells engorged with the beta-glucose cerebroside substrate are seen engorged in tissues such as the liver, the bone marrow, the lungs, the spleen. In fact, all tissues where macrophages normally would be distributed. So the symptoms are related to involvement of all these organs. So the commonest symptoms are hepatomegaly, splenomegaly, which can be massive, and there are spleens weighing 1.82 kilos have been found in people having untreated Gaucher disease. The bone is involved by infiltration of the bone marrow and by avascular necrosis involving the epiphysis, specifically the femoral heads, a bone infarction, and in some cases, there is involvement of the heart as well as the infiltration of the lungs, giving rise to interstitial lung disease. Now, in a proportion of patients, when the brain is involved, this is the neuronopathic form of Gaucher disease, which results in developmental delay, ataxia, seizures, and abnormal horizontal eye movements. So Gaucher disease is not even though it is caused by mutation of the GBA gene and beta-glucocerebrosidase enzyme deficiency, there is a wide variation in the age at onset of symptoms, as well as the severity and nature of manifestations. So at one end of the spectrum, you have people with very mild disease who may be asymptomatic or may have an incidentally detected spleen at 50, 60 years of age. And at the other end of the spectrum, you have severe disease, which is the neuronopathic type 2 disease with intrauterine onset of symptoms. And in between, you may have patients who predominantly come with either skeletal disease, visceral disease, moving into the neurological spectrum, having neurological involvement in the form of hydrocephalus, a cardiac phenotype where there is involvement of cardiac valves, aortic calcification, and eye movement disorders. Now, the the importance of suspecting and diagnosing Gaucher disease lies in the fact that Gaucher disease is a treatable lysosomal storage disease amongst 12 of the treatable lysosomal storage disorders. In fact, Gaucher disease was the first disease to be treated by enzyme replacement therapy. So for Gaucher's disease currently, there are several products which are available. Eliclustat and miglustat are oral drugs which reduce rate at which the substrate is synthesized. The substrate, which is glucocerebroside, these drugs block synthesis of the substrate, whereas imiglucerase, velaglucerase, and taliglucerase are enzymes which are synthetically manufactured by the human DNA recombinant technology in different tissue cultures, and these are available as intravenous injections which are given every 2 weeks, and the treatment is lifelong. And the dictum here is the earlier you start treatment, the better will be the outcome. For optimum outcome, the treatment has to be started as early as possible before permanent organ damage is begins. And that is the reason why the stress is on awareness for picking up symptoms early so that treatment can start as early as possible. And this treatment is lifelong. So it is once you start treatment, this is going to be a lifelong commitment. Now, in obstetric practice, the various ways in which an obstetrician may encounter an LSD, one would be a pregnant woman with a suspicious family history. Secondly, majority would be referred for a prenatal diagnosis. And here there are two possibilities. A pregnant woman has an affected offspring or multiple affected offsprings, one with just a suspicion of a lysosomal storage disease, and a second situation will be where there is a confirmed diagnosis of a lysosomal storage disorder. The third situation would be sometimes premarital counseling. Patients ask about consanguinity. They want to marry their blood relatives and they want to know what will be a risk of having a genetic disorder. Fourth, there are certain fetal presentations, as I alluded to earlier. You can also have very rarely lysosomal storage disorders presenting in a newborn. And then finally, a pregnancy in a woman with a lysosomal storage disorders. And as I mentioned earlier, several of these lysosomal storage disorders are now treatable with enzyme replacement therapy or other disease modifying therapies. So many of the patients who have been treated from very early childhood are now adults who are married and who would be having children. So there would be rare encounters in such a situation where a pregnant woman with lysosomal storage disorders comes to you for a pregnancy and delivery. So the first is a family history. And as you can see here, in this particular family, there all the several males across 3 generations are affected, and the transmission is through a female relative. So in this situation, it is a mother who is having affected sons in 3 generations. In this particular family, the grandmother brought the grandson for a consultation because she noticed that the grandson had coarse facial features, stiff joints, abdominal distension, and had an inguinal hernia that was operated at about 1.5 years of age. She realized that these were features very similar to what her own son, what her own brother had and her own son had, which is why this grandmother brought the child. And this is a typical X-linked recessive pedigree. And I mentioned earlier that there are 2 disorders which are X-linked recessive: Hunter syndrome or MPS 2 and Fabry disease. And the features here with a large tongue, abdominal distension, hernia, joint contractures, coarse faces is suggestive of mucopolysaccharidosis. So this, just by analyzing the pedigree and getting a history of the symptoms, tells you the diagnosis is most likely to be Hunter syndrome here. Now, the second situation is a pregnant woman who comes with a history of a suspected lysosomal disorder in an offspring, but where the diagnosis is not confirmed. So this was a family whom we saw in 1995. This child was seen at 17 months of age, had typical features of mucopolysaccharidosis. So with these features, now mucopolysaccharidosis are a group of about 11 enzyme deficiencies. And in this particular family, the features suggested diagnosis of MPS 1, 2, and 7. Now, these three mucopolysaccharidosis are because of very distinct enzyme deficiencies, but the clinical features are identical. So just by looking at the clinical features, one cannot categorize them as 1, 2, or 7. Now, this family was lost to follow-up. And in the meantime, the mother was pregnant. So she underwent prenatal diagnosis, and the enzyme for Hunter syndrome was analyzed in the chorionic villus cells. All the enzymes were normal, so the pregnancy was continued. But unfortunately, when she delivered, it was an affected female. So we know that Hunter syndrome is X-linked recessive. Females are not affected, only males are affected. So this was an incorrect diagnosis. Now she came with a second pregnancy 2-3 years later. This time a chorionic villus sampling was again performed, and this time the enzyme tested in the chorionic villus sample was for MPS 7 and MPS 1. Now, despite having normal levels of the enzyme, an affected male was born. Finally, after 5 years from the time we initially saw this family, they came back to us. We tested the enzymes, and this time, because there was this discrepancy, the sample was sent abroad to a reliable laboratory for testing enzymes, and deficiency of alpha iduronidase confirmed that the family had MPS type 1 or Hurler-Shea syndrome. So this particular family underscores the importance of reliable clinical diagnosis, testing in a reliable laboratory, and the most important message here is prenatal diagnosis should not be attempted without a confirmed diagnosis in the proband. Otherwise, it is likely to lead to a disaster like we saw in this case. Now, the second situation is when a family comes with a confirmed diagnosis. And in this particular case, the family, the first child was affected with Farber disease. So this is a lysosomal storage disorder involving the joints. So the joints are painful, swollen with these little subcutaneous nodules. These children have early onset of a rapid neurodegenerative disease like this child had. And this child unfortunately expired. However, the parents had preserved the baby's umbilical cord. So from the umbilical cord, the DNA was extracted, and we could perform molecular analysis by sequencing of this ASAH gene, which is the gene implicated in Farber disease. And a disease-causing mutation was identified in the affected child post-mortem, and both the mother and father were carriers. You can see they are heterozygous, so they were carriers for the disease-causing mutation. Now, when they came back to us in the next pregnancy, she came, a second trimester procedure was performed, and the amniotic fluid fibroblasts were cultured, and molecular testing was performed, and the fetus was was found to be heterozygous, which means the fetus was not affected, the fetus was a carrier. So you can see the contrast between this particular family and the previous family, where when we have a confirmed diagnosis, prenatal testing and interpretation of a prenatal report is very, very easy, and we can confidently give them the family can decide whether the pregnancy needs to be terminated or it can be continued. So genotyping is a very valuable tool, not only to confirm diagnosis, but the only way to detect carriers is by doing genotyping. Carriers cannot be detected by doing a enzyme activity testing. Prenatal diagnosis is very reliable with molecular testing, and sometimes for the treating physician, one can predict the phenotype and optimize management. So a little bit of personalized treatment in these disorders by genotyping. Now, the third situation is something that sometimes we are asked, what about consanguinity? How would that impact having patients affected by a genetic disease? And in this situation, I've given an example of Gaucher disease. So consanguinity would mean marriage between blood relatives. And consanguinity in India is practiced among certain communities like the Muslims, or in Maharashtra, where first cousin marriages are common, in South India, where uncle-niece marriages are common. So when we looked at our patient population with Gaucher disease at KEM Hospital, out of 32 patients, 47% had a consanguineous marriage. And when we get a homozygous genotype, so an example of homozygous genotype is this particular mutation, the leucine 483 proline missense mutation. Both the alleles, the one coming from the mother and the father, have an identical mutation. So this is homozygous. So in consanguineous marriages, we expect that the genotype would be homozygous. And in our particular patients, those who were consanguineous, 47% had a homozygous genotype for a GBA1 gene mutation. But if you look at the proportion in non-consanguineous marriages, even non-consanguineous marriages, 53% had a homozygous genotype. So what this tells you is that consanguinity is not the only factor resulting in birth of a patient with an autosomal recessive genetic disease like Gaucher disease. So there are other factors, and the other factors which are important in India are endogamy or inbreeding. So in India, it is a practice for a person to marry within their caste, within their tribe, sometimes within the in a common gotra. So this is where this inbreeding occurs. And in a highly inbred population, like certain tribes in India or certain castes in India, because of a common ancestor, a common founder, there is a large pool of heterozygous individuals or carriers. So even if marriages in such endogamous societies is not consanguineous, the likelihood that two individuals who marry will have a common allele at a given locus is very high. So this is the other factor. Endogamy is the other factor which would contribute to presence of autosomal recessive disorders like Gaucher disease within a specific community. But as yet in India, there is no information or published literature on which communities have a high prevalence of Gaucher disease carriers. And in one of the the study in KEM, amongst our patients with Gaucher disease, 47% of these patients were born to consanguineous mating. And in another study from Gujarat, which had representations from patients from Gujarat, Maharashtra, Rajasthan, Madhya Pradesh, and a few from East India, the proportion of consanguinity was 26% in patients with Gaucher disease. So, so there are different parts of the country. In populations like South India, the proportions could be higher, whereas in North, where the practice of consanguineous marriages is not common, the proportion of consanguineous marriages would be low. But here again, we have to remember endogamy and inbreeding. Now, the fourth situation is certain abnormalities on an ultrasound, an antenatal ultrasound, which may suggest presence of a lysosomal storage disease. And this is presence of recurrent non-immune fetal hydrops, a placenta which is bulky and pale, hepatosplenomegaly detected in the fetus, skeletal abnormalities, specifically short limbs and fractures, abnormal skin in a newborn baby, and increased nuchal translucency. Now, whenever you find increased nuchal translucency, the next step that most obstetricians would recommend would be doing amniocentesis and testing for fetal aneuploidy. but cases with lysosomal storage disorders have increased nuchal translucency. So one must also remember that aneuploidies or chromosomal abnormalities are not the only cause of increased NT. Once the results of fetal chromosomal studies are normal, this child does require further investigations. And in this situation, it is critical to establish a diagnosis referring to a geneticist, because there are implications for prevention of recurrence. Obviously, most of these lysosomal storage disorders are autosomal recessive or X-linked recessive. So there is a high risk of recurrence. And these are couples who would require prenatal diagnosis. And this is just to show you one example of a baby with hepatosplenomegaly. You can see that this configuration of the mouth, this child also had congenital ichthyosis, and on postmortem, the liver, spleen were enlarged. So suspected to have so this baby was a collodion baby, suspected to have a lysosomal storage disorder. In this situation, this is fetal manifestation of severe Gaucher disease, what we call the perinatal lethal phenotype of Gaucher disease. And this child was confirmed to have Gaucher disease and could be advised prenatal testing in subsequent pregnancies. And the other situation is a lysosomal storage disorder detected in the newborn nursery. And this particular family, you can see there are multiple consanguinities. So it's likely that there is a lot of inbreeding in the family. Two previous siblings who had died, one at 6 months of age, another within a few hours of life. And both these children, babies, had typical findings resembling the proband. And this child was right from the third trimester, had an abnormal USG with severe shortening of the fetal long bones, depressed nasal bridge, at birth respiratory distress, requiring supplemental oxygen, suspected to have a skeletal dysplasia, and referred to a geneticist. Now, these features are, this was the baby, and you can appreciate this baby has coarse facial features, a large fleshy nose, fleshy lips, and overall this sort of sparse scalp hair. This child also had microcephaly and certain typical skeletal abnormalities, which led us to suspect mucolipidosis, which is a rare variety of a lysosomal storage disorders. Now, this particular group of the disorders manifesting in the newborn have a high mortality rate and require urgent referral again to a geneticist for a diagnostic evaluation. And one has to be very quick because their lifespan is severely attenuated. This child, in fact, died by 2 months of age and tested positive for mucolipidosis. And again, here the implications are for prevention of recurrence. This is again an autosomal recessive disorder with a 25% or 1 in 4 chance of recurrence in subsequent pregnancies. And this baby, their family can be offered prenatal diagnosis in subsequent pregnancies. Now, coming to the last bit, which is pregnancy in Gaucher disease, we have the pregnancy or the puerperium can worsen the Gaucher disease status. Hematologically, these women can have severe anemia. So an anemia, which itself is a manifestation of Gaucher disease, can get aggravated, and these women may require transfusions. They have cytopenias, particularly thrombocytopenia, which may cause bleeding. Because of the hormonal fluctuations and changes because in the Gaucher disease status, a bone disease of Gaucher disease can be aggravated. They can get bone pain, osteopenia, and in women who are not treated, the spleen can be absolutely huge, filling up the entire abdomen. So this splenic enlargement can result in hampering uterine fetal growth and promoting premature labor. These women are at risk for antepartum and postpartum bleeding because of defective platelet aggregation. They can get postpartum infections if they have undergone a splenectomy. And most of these women, the preferred mode of delivery would be by a cesarean section. And this is in order to prevent splenic rupture. where, if the woman is bearing down in a vaginal delivery, it can provoke splenic rupture. And again, if cesarean section is done, one would avoid a midline longitudinal incision. And the choice of anesthesia for these women, one has to be careful. They may have a spine deformity because of involvement of the vertebral column by Gaucher disease. And even during lactation, the bone mineral density can reduce because of calcium loss in the breast milk, and they can get fractures because of severe osteoporosis. And the other aspect to consider in women with Gaucher disease who are pregnant is the risk of transmission of Gaucher disease to the fetus. So examination and genotyping of the spouse is important. So if the spouse is not a carrier for a GBA gene disease causing mutation, all the children born to a woman with Gaucher disease will be carriers. But if the spouse is a carrier of a disease causing variant in the GBA1 gene, the chance of having affected offsprings with Gaucher disease is 50% or 1 in 2. So this would be another situation requiring antenatal diagnosis by chorion-villus sampling or amniocentesis. Yeah. So we had an opportunity to manage a pregnancy in a woman with a Gaucher disease. This was a 32-year-old girl who initially in childhood had received enzyme replacement therapy, and then she qualified for the oral molecule with substrate reduction therapy, which is eliglustat. Now this lady, she got married, and she had 2 pregnancies. Now eliglustat had to be stopped the moment the pregnancy, she suspected she was pregnant, and during pregnancy she received enzyme replacement therapy. And you can see here how in both the pregnancies the hemoglobin value, so before pregnancy she had a normal hemoglobin. During the pregnancy with dilution, the hemoglobin has dropped to as low as 9, but there is recovery in the puerperium. The platelet counts were stable, though in the immediate postpartum period, she had a mild reduction in the platelet counts, but this was an uncomplicated pregnancy, an uncomplicated a labor. Gaucher disease status continued to remain stable. There were no requirement for transfusion. There were no new bone lesions, and she could successfully breastfeed her child. In fact, this lady was very smart. While she was receiving enzyme replacement therapy, she quickly conceived the moment she stopped breastfeeding her first child and finished her childbearing, all within the period of time when she was approved to receive imiglucerase, which is enzyme replacement therapy. And imiglucerase is safe in pregnancy. About 150 pregnancy outcomes are known. There has been no documented teratogenicity. The use is the benefits of using enzyme replacement therapy in pregnancy far outweigh the risks. Very rarely there may be fetal demise. On the other hand, eliglustat has shown in animal studies that there is some teratogenicity, fetal harm, though in high doses, which are 6 times higher than the recommended doses in humans. And eliglustat is to be prescribed if the potential benefit justifies the potential risk. So with that, the key messages that I would like the audience to carry home is genetics. For lysosomal storage disorders, genetics is a value added service in obstetric practice. In a patient with a family history, one must spend a little bit of time to obtain the family history and specifically inquire for presence of consanguinity. Prenatal diagnosis, if it is offered in at-risk families, one should ensure that the diagnosis is established in the proband, preferably before the woman conceives, so that a prenatal procedure for prenatal diagnosis can be planned well in advance. And here it is very important for the obstetrician to convince the family to undergo diagnostic testing. We get many patients who have physical features for example, of a mucopolysaccharidosis, which is never confirmed either by enzyme testing or by molecular testing. They come to us late in the second trimester when one really is, the family and the doctor will get stressed out to obtain a prenatal sample and a result within the legal limits of medical termination of pregnancy. In families who are having affected children, carrier screening should be offered or practiced not only in the parents of the affected child, but even the extended family, the first degree relatives, the parents, brothers and sisters, other siblings of an affected person, all should undergo carrier screening. Such families should be referred for genetic counseling, and there has to be a dialogue with the geneticist to decide what would be the most appropriate test, and very importantly for pre-test counseling. So Suyog, is there some issue?
Yes, ma'am. Sorry.
Yeah, my screen has suddenly gone blank.
It shows end of slideshow, so I think it's the
Oh,
end of the presentation.
okay. So it prematurely went on the blink. So anyway, that was the end of my presentation. Thank you very much for a patient hearing. And Suyog, you can let me know if we are to take questions, or the Q&A session is going to be a little later. Thank you very much.
Thank you so much, ma'am, for an extensive yet a very crisp elucidation of the salient features of lysosomal storage disorders and the importance of prenatal diagnosis. Thank you so much. We'll be taking the Q&A sessions after the panel discussion. Correct, Suyuk?
Yes, that's right.
Yeah. So now going ahead, I would first like to invite Dr. Hrishikesh Pai, who has joined us, who has taken out the time to join us. He's the leading gynecologist and an IVF specialist. He is currently the president of FOGSI. We welcome you, sir, to our nice.
Yeah.
Small, yeah. Thank you. Thank you so much. Okay. So we'll go ahead with the panel discussion now.
Yes, sure, we should.
Yeah. I would like to now invite our panelists, Dr. Mamta Muranjan ma'am, Dr. Hrishikesh Pai, and Suyog Sathe for the next panel discussion. A nice discussion on what can be the future, what next we should do. So the first question to Suyog: can you tell us about the current situation with respect to lysosomal storage diseases in India? And what are some of the biggest challenges which are faced by the patient community?
First of all, big thank you to all the panelists, Dr. Mamta as well as Dr. Pai, to take the time to join us. So to talk about the situation in India, as we know, LSDs are quite rare disorders with an average incidence of about 1 in 70,000 live births. So as a result of this rarity, because of the small market size and the high cost of research involved, the treatment is prohibitively expensive, and it costs anywhere in the range of INR 50 to 40 to 50 lakhs to the tune of 1.5 to 2 crores per patient annually, since this is a lifelong treatment. And the cost of treatment also depends on the patient's body weight, because as the patient's body weight increases, the dose required also increases. So, clearly, this treatment, not only in India, but throughout the world, it cannot be afforded by any ordinary individual. And it is supported by governments and insurance companies in most countries, including in developing countries such as Egypt and many other countries. So in India right now, although with the untiring efforts of organizations like the LSDSS, the government of India has recently come out with a national policy for rare diseases last year. So however, it has not offered any substantial and sustainable financial support for the treatment of such patients. So although there are no official estimates of LSD patients in India, we know around 600 to 700 patients who have currently been diagnosed with LSDs in India. Out of these 700 patients, only around 200 patients are being provided treatment on humanitarian grounds by a few global pharma companies, such as Sanofi. But the rest of the patients are unfortunately without any treatment and support, and they are left to the inevitable. So although LSDs are rare in India, as Dr. Mamta Muranjan said, because of prevalence of practices such as high consanguinity, as well as our large population, it is expected that the prevalence of LSDs will be much higher in India than other parts of the world. And also with the increasing awareness amongst the clinicians about the diagnosis as well as the clinical management of LSDs, we have more and more patients getting diagnosed, but unfortunately they are without any treatment because of the prohibitive cost, which I think is one of the biggest challenges facing the patient community. So besides creating awareness about the diagnosis and clinical management of LSDs, I think it is also very important that all the concerned stakeholders, such as policymakers, geneticists, gynecologists, come together to focus on the prevention of these disorders, which is also one of the major reasons of conducting this study.
Thank you so much. Yes, the affordability is really a big issue. So for the next, I would like to invite Dr. Mamta Muranjan. Ma'am, what are some of the most effective prenatal tests for LSDs, and at what gestational age would you suggest that these are performed? Ma'am.
Thank you, Sakshi.
Yeah.
So when we're talking about prenatal tests, we are specifically dealing with a family who has an affected child with a lysosomal storage disorders. So in this situation, the disease confirmation is already made. The parents are carriers. We would offer prenatal diagnosis either by a first trimester procedure, which is chorion villus sampling, or a amniocentesis, which is a second trimester procedure. And one always prefers a diagnosis as early in the pregnancy as possible. So a chorion villus sampling would be preferred in these families. So, if anything, retesting is required, if a sample is inadequate, there is enough time, and the family and the lab is not rushed in these situations. So personally, I would recommend a chorion villus sampling for prenatal diagnosis is any affected family having a confirmed diagnosis in a proband.
Thank you, ma'am. Thank you so much. To Dr. Pai. Good evening, sir. You have recently assumed office as the president of Federation of Obstetric and Gynecological Societies of India, FOGSI. What role do you see FOGSI and the obstetric and gynecological community play in prevention of LSDs and other genetic disorders? Sir.
Thank you for inviting me. Actually, basically, we need to have an integrated approach to this problem. And this time the slogan of my campaign is, it's called Badlao, change. And there are 3 points to it. There is one is integration. It is called Ekikaran. Second is equity, means you need to give equal treatment to everyone concerned. And third is technology, Takniki it is known as, which is using technology to bring about this change. So like we are now in the process of getting a 10 to 15 minute womb to wellness kind of video, which will cover everything in the woman's life. So one of the things that will, because you have to touch the people, so we have to do a B2C campaign primarily. So the B2C campaign has to be an integrated B2C campaign. You can't have someone talking about lysosomal disease, someone talking about malaria, someone talking about anemia. So these have to be integrated, because when you touch a woman in the clinic or in the community, you have to do it at one point. You have to tell them everything. You have to bypass. So what they would have learned, so many even educated people, they don't know. Today only, I was talking to my CEO, who is done IIM, from IIM. She said, what is lysosomal storage disease? So I was telling her I have to give a talk on lysosomal storage disease. So they don't even know what is that. So we have to, what is the thing we have to give as far as genetics is concerned? We have to tell the people, our people in the country, 1 billion, 1.3 billion of them, that there is something called a genetic disorder, which is can be prevented either by, so the genetic disorder has to be used. So who should be tested for genetic disorder? The ones who have affected by the time damage is done. Na? I was just calculating 30 million people are born, 30 million deliveries every year. Last year, 30 million. 30 million into 70,000 is 2100 lysosomal people are being added to the population every year. You understand? It's not 300, it's not 600. It's a tip of the iceberg. No? You are adding 2100 every year because 30 million are there. Your incidence is 1 in 70,000. So you have to tell everyone that if there is a slow learner in your family or in your immediate family, or if you have a consanguineous relationship, or if you are more than 35 years of age, then there is a chance that you may have a problem in your hand. Your child may be not a good, may not be a slow learner, may be a slow learner. So you need to do testing, and the testing has to be done, and then ultimately we have to look at how we can, as the NGS has come, I have my own NGS lab also, but I do only in-house testing, I don't do it for others. So we do pre-implantation genetic testing. We've done a lot of now PGTM for multiple disorders, and poor people I give them at very low cost because for me it's a kick, it's an adrenaline, it's not, I don't do it for the money part of it. So as far as I'm concerned, the testing can be done, and obviously we have to go for expanded carrier screening. So in high risk populations, we have to go for an expanded carrier screening. Already we are offering it to our donor patients. So if there's a donor who's a for egg donation, I do expanded carrier screening. I screen them for 3,000 genes already. So, then this expanded carrier screening is becoming cheaper and cheaper. So day by day, so we do a carrier screening where we test for around 3,000 genes plus SMA, which cannot be tested by NGS, and DMD and Fragile X syndrome. I test for all these syndromes. And now a lot of people abroad, when they get married, they need to catch the first person, the first child has to be catch, caught, not later on. That the damage is done. You have destroyed the family by allowing the first child to be born. So the whole thrust has to be how to get the first, prevent the first abnormal, or we can't call it abnormal. I know that your terminologies have changed. So, a slow learning child, how do we catch that first child and prevent? So, the another thing is, which I would like to tell all of you is that PGT is going to be the future. So, amniocentesis or chorion biopsy followed by termination is destructive medicine, I call it. You have to do constructive medicine, means we have to prevent pregnancies, because terminating a child is not a good, conceptually a good thing. We need to prevent a child from being born. So all these things are important, and the only way one can do is by concentrated campaign. Again, another is targeting is B2B also. GPs don't know about it, Ayush doctors don't know about it, gynecs don't know about it. So the information has to be targeted B2C and B2B. So once the information is given, then people are more aware of what it is all about. So I think basic, and then government also has to ultimately at some point in time, maybe 10 years down the line, when NGS become very cheap, it will cost 500 rupees for an NGS testing. Then at that point in time, we can do it routinely. For example, now in AMH tests have become so cheap that we do it for almost all women to see what is their ovarian status. So similarly, as the technology advances, more and more people use the technology, it will obviously become cheaper. And that's where we can apply it for the mass. And as I told you, my second part of my campaign is Samanta, equity or equality. That is very important. We have to treat everyone the same way in our country. So these are the things how we can do it. And one of the things which in my campaign is genetics, but preventive genetics. So even when they come to you, you must ask the question: are you having a problem, a slow learner child in your family? Do you have some child who has got a neurological deficit? Do you have someone in your immediate family who has got a neurological deficit? And at the same breath, you have to also ask, are you being, by any way, are you having facing violence in your family from your husband? So all these have to be done at the same time. Are you having a cancer in your first cousins? So ultimately, I feel that robots will come into the consulting room because these cannot be done by humans. The robot has to ask these questions to everyone who sits in the consulting room, and integrated questioning has to be done, and pickup has to be done. So it has to be cancer pickup, it has to be genetic pickup, it has to be violence against women pickup. Everything has to be done at the same time. When the person comes to your consulting room, she's waiting to come to your clinic inside. That is the time you need to target them, and that is the time you need to elicit the history and take effective action.
So much, sir. Really extensive work from FOGSI, and great. Thank you so much.
Thank
Next,
you.
thank you. Next, Dr. Mamta ma'am. In India, prevalence of LSDs is likely higher considering the large population and also practices like consanguinity in certain regions and communities in India. Would it be advisable to do a universal prenatal testing for LSDs in India, especially for such kind of at-risk cases?
Okay. Thank you, Sakshi. That's an interesting question. So when we're talking about prenatal testing, there are two aspects. Is it prenatal screening or is it prenatal diagnosis? Now, for prenatal screening, like is commonly practiced, say for Down syndrome, which is seen in 1 in 700 pregnancies, or neural tube defects, the prenatal screening requires a test which is simple, which is cost effective, which can be easily performed, which is sensitive, specific, and so on. So if we look at lysosomal storage disorders, it's a heterogeneous group. So there is no single biochemical or analytical test which can be applied for screening a huge population. Nor is there any specific ultrasound marker like you have NT for Down syndrome or some other disorders. So we are not talking about prenatal screening of all pregnant women for a lysosomal storage disorder. But if you know there is a family at risk, then definitely the parents' carrier testing would be done. And in these high-risk groups, a prenatal procedure, which is an invasive procedure, would definitely be advised. We are not talking about prenatal diagnosis offered to every pregnant woman or pregnant women at large, because one, lysosomal storage disorders are rare. If you just take Gaucher disease, where 1 in 60,000 newborn babies is affected, and the prenatal testing is going to require an invasive procedure like chorion-Willis biopsy, you would have to subject 60,000 women to a chorion-Willis biopsy to detect one affected child. So that is not sensible, that is not ethical, that is not advisable at all. So as far as lysosomal storage disorders are concerned, a prenatal testing, prenatal procedure would be advised only to at-risk families having an affected child, having an affected first-degree relative, or having ultrasound or other abnormalities in the fetus.
Yes, ma'am. Thank you so much, ma'am. So, an affected diagnosed sibling would be a better one?
So an affected diagnosed sibling would definitely, such a couple would be advised prenatal testing by a chorion-Willis sampling. And of course, the other situation also is where couples who don't want to do prenatal diagnosis followed by a termination. Dr. Pai said that, you prevent, but don't resort to such destructive things. So here would be a role in such families with an affected offspring to have undergo a prenatal, a PIGD, where you would actually do a, embryo tested for presence of a Gaucher gene disease causing mutation. And here there is a caveat: the mutation in that specific family would have to be known. Now, in India, we know that one mutation, the leucine 483 proline, is seen in about 50% of people with Gaucher disease. But in other 50%, the mutations are a variety of mutations are seen. And some families have a private mutation. So you cannot have a common mutation panel for a disease like, say, Gaucher disease. Certainly not for LSDs. The testing required for the variety of mutations is very, very wide. So if you were to do a PGD for any LSD, it would necessarily require confirmation of the disease causing mutation in that specific family and then looking for the same mutation in the embryos.
Can I say something? So what we do normally is we do a proband testing. So the blood is collected from the affected child and the two parents, and that is sent to the lab where the actual mutation is analyzed and found out. Then only we do the actual PGD, we do the IVF, create the embryos, take them to blastocyst, then trophectoderm biopsy is done and the blastocyst is frozen in individual straws and numbered. That biopsy is then sent to the lab where already they have, using Sanger sequencing, they have already, they are ready with the probe, which is already done. And then with that probe, you check the embryo and see whether it is affected or non-affected. So it's a very exciting, but even with PGD, we always advise that antenatal testing be done because it is done on 3 to 4 cells. So very less DNA is there during amplification. There may be an allele dropout, and that's why we need to do a antenatal testing also as a backup. Okay, and I'm really telling you that, and that's where all the pediatricians and all of you need to know this, because these parents are very scared to have the second baby. And that is where you need to send them for the PGD. And let me tell you that because we are good doctors, so we'll definitely, if patients are not affording, we'll do them at a lesser cost. But we should do it. That is what the challenge. Now we must do it. And of course, the biggest single gene defect in our country is thalassemia. And we are doing a lot of thalassemia work at present. But these other genetic disorders can also be done now. We have started doing them. So it's quite easy to do it now. And quite economical also. Within a 2.5, 3 lakhs, we can do a whole PGD cycle. Even for thalassemia cycles, I've brought the cost down to nearly 2 lakhs now. So, and people can afford it. When they can afford a liver transplant for 30 lakhs, they can definitely surely afford a PGD. So it's become quite reasonable. And this is all the pediatricians and all the neurologists and all of you like Mamta have to send them for the second baby. That's very important because they are very traumatized. So they don't want to have the second child, and that they have to be assured, and then only we can have the second child. But I am saying that in the larger, by the way, I'm just in talks with
Rishikesh, we seem to have lost you.
where non-invasive prenatal testing can be done only for the trisomy 18, 13, and 21, and some can amplify and even do single at a time. You hear me?
Yeah, yes, sir.
No, I think I
Now.
lost them.
Yeah.
So there, a time is going to come where NIPT, which we are now doing routinely for patients, and it is, by the way, more accurate now than a Korean biopsy. Of course, invasiveness more accurate than the biochemical marker. NIPT is more accurate according to me, and of course, at present it is being confirmed by amniocentesis or Korean biopsy. But the time will come where the accuracy will be very good. The false negative, false positive is going to be very low. And this person I'm talking with in Australia, he has a new technology, can amplify the fetal DNA which is leaked in matter and even do single gene analysis. So it's going at a different level, and maybe 30 years down the line, you'll be able to collect the blood of the mother and check for whole genetic profile. Let me tell you this.
Thank you so much, sir. Yes, we can do a lot ahead. Future awaits us. So
Why I was saying this now is prevention is more important than cure, because the costs are very low. Of course, the companies are doing a great job, and there also the cost of these medicines, I'm sure, will come down as the years pass by. But we need to prevent rather than cure.
thank you, sir. Coming to the next question, Dr. Pai, sir, are there currently any definitive guidelines or protocols in place for prenatal screening for genetic disorders in India? If not, would FOGSI consider coming up with such guidelines to this effect that would help in preventing further births with LSDs and other genetic disorders, especially in such high-risk pregnancies with consanguinity?
Yeah, I think we already have some guidelines. There are some GCPRs, but not so many specific ones. But I'm planning to have 30 GCPRs this year, good clinical practice guidelines, and we will work on a genetic guideline for maybe overall genetic analysis rather than the specifically, but also can have a sub para for the rare genetic disorder. So I would definitely come out with this guideline, and that's why I told Suyog that you bring me in on this panel, because I'm very interested in doing all these things. Of course, as a FOGSI president, you have very less time. So I'm a man in a hurry. I'm doing 20 things at the same time. But we have a lot of associations. Indian Association of Pediatrics is there, and so many other allied associations are there, which are now working together in tandem. Plus, our Ayushman Bharat is there. So everything is coming together, and I'm sure that India will be able to. The load, patient load is massive. Now, 1.3 billion is not a joke. So it is like 10, it's like 13 United Kingdom population. So, I feel positive about it. In last 75 years, we have done fantastic work in the healthcare sector, and I'm sure we'll do better in the years to come.
Thank you so much,
Uh,
sir. It's really great listening to this and thinking that, yes, more guidelines are going to come up and you're so interested in genetic disorders makes us feel very nice. To Suyog, next question would be, can you tell us a little about the LSDSS, that is the Lysosomal Storage Disorders support group, support society, and the work that is being done, which is going on because of the LSDSS for the LSD community in India?
Actually, the journey of LSDSS started way back in 2010 when the parents and caregivers of some LSD patients across India came together to form a patient advocacy group and give a unified voice to the challenges faced by such patients. So LSDSS is actually the first organization in India that brought the topic of LSDs and rare diseases to the attention of policymakers and even the judiciary in India, and has kept it a live subject ever since. So since its foundation, the LSDSS has played an exemplary role in improving the lives of LSD patients in India, various patient advocacy and awareness initiatives. So, in fact, LSDSS was the first organization in India to commemorate the International Rare Disease Day back in 2010. And since then, we have been raising awareness about LSDs by observing the Rare Disease Day as well as various disease-specific awareness days like Gaucher Day and MPS Day every year. So apart from that, we also undertake various CME programs for healthcare professionals across India to educate them about LSDs in order to improve the diagnosis as well as the clinical management of such patients in India. And we have also undertaken various media awareness campaigns across India to increase awareness amongst the policymakers, key stakeholders, as well as the public alike about the various challenges faced by rare disease and LSD patients. So through these unwavering efforts and initiatives, the LSDSS has been able to achieve many historic milestones in the last several years. The biggest one, I would say, was the National Policy for Rare Diseases that was notified by the Government of India last year, which actually came as a result of a court case filed by the LSDSS in the Delhi High Court. So yeah. So besides, so LSDSS has also been successful in getting state-sponsored ERT treatment in various patients and states like Karnataka, Kerala, and Tamil Nadu. So through some PSUs like the Indian Army and Maharashtra Police and other organizations. So yeah. So to summarize, that was just the gist of the journey that LSDSS that we have until now. But we still have a very long way forward, and we will keep striving to overcome the challenges.
Thank you so much. Personally, I always like listening about what are the things done by LSDSS and how far it has come and what the future holds. It is great listening to it. So here we are at the end of the panel discussion. Before closing, I would like to take some questions if there are any questions in the chat box, or anyone would like to ask some questions. Actually, I had a question to Dr. Mamta ma'am, if she's there. Yeah.
Yes, there I am.
Ma'am, I just wanted to ask, if we have first child who is not the expired, but had only an enzyme report, which had beta glucosidase low, but didn't get a genetic testing done. So can we do a prenatal on the basis of enzyme study?
So most definitely, yes. In fact, before molecular testing was available, we have been performing prenatal diagnosis on Corios villus sampling as well as amniotic fluid, cultured amniotic fluid fibroblasts by measuring the enzyme activity in these tissues. So yes, definitely biochemical testing will maybe not as accurate as a molecular testing, particularly when there's an overlap between an affected child and a carrier, or a carrier and a normal healthy person. So with these, with understanding of the advantages, disadvantages, biochemical testing is an alternative. If a molecular testing is not, the proband is not available, or the proband sample is not available for a molecular testing. But I think now with technology, where you have whole exome sequencing, clinical exome, NGS based technology, even if a proband is not confirmed, you can test the parents, and you would identify the specific gene, the specific mutation, and offer a prenatal sample after testing the parents. So a proband not being available is no longer an obstacle for molecular testing for the purpose of a prenatal diagnosis.
Yeah. Thank you so much, Nam. That was from me. That was my query. Any other questions? Any other questions anyone would like to ask? Okay. So after this exciting and extensive discussion we've had, time to wrap the session. I would now like to thank our speakers, Dr. Mamta Muranjan ma'am, for always having such vast knowledge, and her flair for teaching is just enthralling. I love hearing her speak. And Dr. Hrishikesh Pai, leading gynecologist, IVF specialist, thank you so much for being here and telling us
Thank you.
so much about the further plans that you have from the obstetricians and gynecological part of you. And this would not have been possible without the help of Sanofi, LSDSS, that is the Lysosomal Storage Disorders Support Society, and the International Gaucher Alliance, and most importantly, Suyog, who has helped us all together, brought us all together for the day. And we have learned a lot today, and I've enjoyed moderating the session. Thank you. Thank you so much, everyone.
Thank you, Dr. Sakshi, for moderating the session so well. And also thanks to Dr. Mamta for the wonderful presentation. And Dr. Pai as well. Thank you so much for sparing your valuable time. And we really look forward to working with you and FOGSI, towards the prevention of LSDs and other rare disorders. Thank you so much.
Thank
Thank you.